Okay, we'll make a start. So, welcome and thank you for coming to the Decide conference, and welcome to Scotland. Not yet independent. Who knows how things will be at this time next year. So my name is Sean Treweek, and I'm part of the coordination team for the Decide project, which means therefore that I'm absolutely delighted to see so many people out there in front of me. So I was looking through the list of delegates. We have registered about 270 individuals, and that's from more than 20 countries. So we are genuinely an international conference, again, which makes me and the rest of the Decide group extremely pleased at the interest in the Decide project that demonstrates. So I don't actually have much to say in this introduction. My main role is housekeeping, and then we'll get straight into the main program for this morning. But I do have a list of things that you need to know. So the first one is, if you are lost on the way to a workshop, or you have another question about some aspect of the, proposal about the conference, then look for somebody who has a yellow badge. So there are some helpers, and their role is to do exactly that, is to take you to wherever you need to be and help you with any problems you might have to the best of their ability. The next thing would be that if you have not signed up for a workshop yet, that's fine. You can still do that at reception. It helps with the planning of chairs more than anything else. So if you haven't registered for workshops, please do that. You can do that at the reception desk. We originally planned to have this meeting next year at the end of the Decide project. And we moved it to this point in Decide with about a year and a bit to go because we want feedback. We really want to tell you about things we have done, but we are very, very interested in hearing what you think of that. Give us your suggestions, your opinions. So therefore, we have a number of different ways in which you can provide feedback. Obviously, you can ask questions both in these sessions and in the workshops and contribute in that way. But there are some other ways as well. So you'll all have noticed that in your delegate packs there are a couple of postcards. If you can think of a comment, you have a suggestion, put it on that postcard. There's a post box at reception. We'll take those. We'll look at all of those after the conference, but we'll also look at them during the conference and see if we can get some of them addressed during discussions and plenary sessions as well. We'll try our best to do that. There's also a notice board at the front, so if you wanted to put notices up there, perhaps to meet a colleague or to give another suggestion, then please use that. We'll also have a look at that to see if there are questions that we can bring to these sessions or to the panel discussions as well. We will look at everything after the conference, so there's no danger that if you make some suggestion, it will not go unread. We also would be very, very keen for you to look at some of the stands. If you notice, there are lots of posters. Please look at the posters. These are in the coffee area. But there are also a number of stands. So Sign has a stand, NHS Inform has a stand. Have a look at those, see if there's information there that you might find useful. Get into a discussion with them. This is mainly for speakers. Some of them, you may have heard this, or workshop leaders. Just try and make sure that everybody is feeling comfortable, not too warm, not too hot. So be aware of your audience. So if anybody in the audience is feeling that the air conditioning is too high or too low, then raise a hand, and the person or persons leading that session will try their best to do something about it. And the next and important thing is that we have already had today a fire alarm, or a test. So if you do hear the alarm go again, it means the building is on fire. If you could then please leave, that would be great. We also have people tweeting, so we have some dedicated tweeters. You'll see that we have Twitter hashtags for those of you who know about those things. For those of you who don't, you really should, because it's cool. But that's the twittering. So if the building is on fire and you're a Twitterer, please leave and then tweet about that fact. And the last thing before we get into the meat of the morning session, because I may not get an opportunity to do this again, is to thank the three people who have done most to organise this meeting. which is Robin Harbour, Leslie Forsyth, and Bill Slater. You'll see them throughout the session. They are looking slightly more frazzled than the rest of us, but they have done more than anybody else to make this conference work. So before we move on, I'd be very grateful if we can just show our appreciation to the three of them. Thank you very much. And now, slightly ahead of schedule, which is I'm hoping will be a notice to everybody leading one of these sessions, we'll start with the meat of the meeting, or this morning's session. So what we want to do first, until lunch, is give an overview of certainly the project, but guidelines and issues linked to guidelines, and also the European Union perspective on this work. As you know, the DECIDE project is funded by the European Union's 7th Framework Programme. Our opening address, though, is by somebody who's not formally linked to the DECIDE project, which is Professor Bruce Guthrie. Bruce is a professor of primary care medicine at the University of Dundee and leads the Quality, Safety and Informatics Research Group at the university. He has wide research interests, but they include the definition, measurement and improvement of quality and safety, and his current work is focused on high-risk prescribing and multimorbidity, including collaborative work with both NICE and SIGN on how guidelines could better account for multimorbidity. He also finds time to practice clinically as a GP, works in a socially economically deprived area of Scotland, and is the academic lead for the Health Foundation-funded Scottish Safety Improvement in Primary Care Collaborative, as a member of a number of National Health Service advisory bodies, including the NICE Quality and Outcomes Framework Indicators Advisory Committee. And you'll see from the title that Bruce's focus for this talk is on primary care and multimorbidity. Bruce, thank you very much.
So I'd like to thank Sean and all the rest for asking me here. I'm not connected to DECIDE, and so some of this may only have peripheral links to the rest of the programme. But it kind of reflects that, you know, clinicians, doctors are all pretty self-centred, and so what I'm going to give you is a fairly self-centred view of using guidelines as a practitioner, as a primary care practitioner in particular, although it draws on a whole pile of evidence, which I hope you may find interesting. So, I mean, how useful are guidelines? I mean, just to be quite clear, there is a short answer to this, which is that I think guidelines are very useful. Guidelines have been a really important way of taking a whole pile of research evidence and making it more usable for clinicians. Because otherwise, a lot of this evidence was really not very accessible to clinicians. But of course, the long answer is that when you come to use guidelines, it all depends, and sometimes they're useful, sometimes they're not. And in particular, I was going to talk a bit about using guidelines when you've got multimorbidity, so when people have more than one condition, or polypharmacy, people are already taking large numbers of drugs, and hint about some issues about life expectancy, which are not really currently part of guidelines. So, you know, guidelines of multimorbidity, this is what I'd call a kind of a dear, oh dear, oh dear paper. So it's a common research method where you take something in the real world and you apply a kind of research framework to it and you say, dear, oh dear, things need to be better, and then you make no suggestions as to how they might be better. So this is a UK version of what was originally a US paper by Cindy Boyd in JAMA. And you define a patient who you claim to be typical. So 78-year-old woman, she's got 5 conditions and smokes. So she's had a myocardial infarction, she's got type 2 diabetes, she's got some wear and tear in her knees, she's got chronic obstructive pulmonary disease, and she's depressed. So, you know, I mean, there won't necessarily be that many people of this age with these 5 conditions, but this probably isn't that atypical. And if you then pick up the NICE guidelines for this, then they recommend a minimum of 11 drugs. So kind of all people with these conditions in moderate severity, you essentially get 11 drugs. Depending on her symptoms, depending on whether or not her diabetes is well controlled, for example, you can add another 10. She herself is meant to do a minimum of 9 self-care or lifestyle activities, most of which are every day. the management of diet and diabetes and everyday activity. If you just follow if you take the follow-up recommendations, then you're looking at 8 to 10 routine primary care appointments, 4 to 6 other medical appointments, 8 to 30 psychosocial intervention appointments, smoking cessation if she wants it, and a pulmonary rehab if she wants it. And kind of that's not necessarily that abnormal, but of course none of this addresses anything that she might want to come and see me about. But when she comes in, all of this are things which I'm meant to be doing something about, and this is what my computer tells me to do. I get a whole pile of prompts every time this woman comes in, unless all of her numbers are beautifully perfect. Of course, the real feature of these papers is that the way you make them work is you very carefully select the conditions you're interested in. And so, of course, MI, diabetes is an easy way of creating multiple drugs, which wouldn't be the case if she had other conditions. But that kind of level of multimorbidity is not that abnormal. So this is data for about a third of the Scottish population. It's data extracted from GP records. And what we're counting are 40 chronic conditions. So those 40 chronic conditions are probably about half of my workload, the other half of my workload being several thousand other conditions. And if we count chronic conditions, so this is by younger people over on your left, older people over on your right. Unsurprisingly, as you get older, you get more people with multiple conditions. What's kind of not totally apparent in here is that if you have any chronic condition, then actually the majority have got more than one. Multimorbidity is not abnormal. It's not a minority sport. Actually, it's the norm. And although there's many more chronic conditions in older people, actually the bulge in the population is in younger older people. And so there's more people under 65 with multiple conditions than there are over 65. And the patterns kind of vary. So in middle age, quite often this is physical and mental health comorbidities. In older age, there's more of an accumulation of physical comorbidities. And from a guideline perspective, of course, the evidence largely comes from here. So the middle, but down towards the right and the bottom of the graph. But actually, who I spend all my time seeing are people over here. Okay? People who aren't ill don't come to me. The people who dominate healthcare use are people in the last 2 or 3 years of life who typically have lots and lots of conditions. And that's not the population that evidence is typically created in. Of course, multimorbidity, it all depends what you have. So this figure is showing for the row conditions, so coronary heart disease, hypertension, heart failure, what percentage of people with the row conditions have one of the column conditions. So it's the same conditions in a grid. And so 52% of people with coronary heart disease have diagnosed hypertension. And of course, some of these combinations really make no difference. They make no difference in guideline terms. They make no difference in clinical practice. Hypertension, in terms of its treatment, is completely contained in coronary heart disease. It really makes no difference. It's not complicated for me. It's not really that complicated for guidelines. If you look at some of these other combinations, though, so heart failure and chronic obstructive pulmonary disease, clinically that's a real issue. When someone gets a bit more breathless, is it their heart? Is it their lungs? Is it both? Can you tell? And historically, at least, that's an example of a situation where guidelines could be in conflict, where heart failure guidelines tell you to use beta blockers. Historically, there were issues about whether you could do that in COPD, although that's an example of one where there is now pretty good evidence. And if you were thinking about where the big gaps in our healthcare system are, well, actually, the biggest gap is not between physical specialties, but between physical and mental health care. And pretty much it doesn't matter what condition you have over here, about 1 in 5 people over here, of any of these people with any of these conditions have got depression. And depression is known to be deeply problematic, both in terms of physical disease outcomes and depression outcomes in people with physical disease. One of the ways all this expresses itself is then in the number of drugs that we make people take. So this is 1995 data. This is dispensed prescribing data for one region of Scotland. So the total population is about 400,000 people. And what we're counting here is the number of drug classes you get dispensed in the last 84 days. This is from 1995. So same kind of format, young adults, older adults, and it's percentage of people in each age group who are on no drugs, or who are dispensed no drugs. They may be buying some over the counter. So none, 1, 2, 3, 4. You get colour change, 5, 6, 7, 8, 9. Colour change, 10, 11, 12, 13, 14. And down here, 15. So So when I was a student, polypharmacy was 3 or more drugs. Geriatricians where I trained would stop every single one of those drugs if you were taking more than 3 and you were admitted and you were older, because they were clearly poisoning you. The literature usually says 5 or more. However, there's been a change over time. Since 1995, we jump forward 15 years, it looks like this. And so, at any age, people are now dispensed many more drugs. It's now pretty normal for older people to be on 5 or more. And so the literature is slowly shifting, saying, well, maybe 10 or more is what matters. And certainly NHS Scotland is saying we should focus on 10 or more, because 5 or more is just too many people. And you get an increasing slug of people taking 15 or more, or dispense 15 or more drugs. A consequence of that is interactions. So if you look at interactions which our formulary says are potentially more serious, then between 95 and 2010, about 4% have a potentially serious interaction, doubles to 8%. And the thing that drives that is the number of drugs you're on. So unsurprisingly, the more drugs you're on, the more interactions you get. So you can't have an interaction if you're not taking more than one drug. If you're taking more than 15, then 70% have got a potentially significant interaction. So most of these interactions don't matter. They're potentially serious, but in individuals they don't particularly matter, but they're a marker of complexity because, of course, these are only the interactions that we know about. And most interactions are probably unknown, and they're all pairwise interactions. We know very little about how interactions work when you take multiple drugs with small overlapping interactions. So what's the problem? Well, I mean, guidelines largely ignore multimorbidity. I mean, they largely ignore comorbidity. They usually only touch on comorbidity where things are related. So diabetes guidelines refer to ischemic heart disease guidelines. And of course, you can't make a guideline account for all possible combinations. So a comorbidity approach isn't necessarily that helpful. At least you can't do it on paper. You may be able to do it better electronically. And guidelines reflect the evidence base. And the evidence base is a condition-by-condition evidence base, where typically we exclude, or trials exclude people if they're complicated. They exclude people with multiple conditions, they exclude older people. But it's not clear to me that applicability is always well handled by guidelines. Guidelines really don't make it easy to compare treatments in terms of benefits. So if you look at NICE or indeed SIGN, I get strong recommendations to give several drugs. But some of these drugs have orders of magnitude different size of benefit. And so if you've got severe left ventricular systolic dysfunction, an ACE inhibitor is a very large benefit. Is there any benefits taking on osteoporosis prevention for primary prevention? Well, maybe, but the size of the benefit is clearly very, very different. And finally, and I'm not quite sure how you get around this because it's the evidence, guidelines are all about decisions to start treatment. They're not about stopping. But stopping is in some ways the more interesting one. So applicability is one element of directness in the grade criteria. And that's, patients and trials may differ from those being treated. That's the one that interests us. And of course, evidence is almost always indirect in this way. So about half of people with newly diagnosed diabetes are eligible for relevant trials of glycemic control. It's less than 25% of people with heart failure. It's less than 10% of people with COPD. And almost all trials exclude people either on the basis of age or on the basis of common medical conditions, usually without any strong justification. So NICE do have a statement about this, so they recognise it as being a common problem. They say the GDG may wish to extrapolate to the recommendations from evidence, but will need to make its approach explicit, stating the basis for extrapolation and the assumptions. If you look at NICE, if you look at more recent NICE guidelines where there are grade tables, it's very rare to ever see a trial that's being stated to have serious indirectness. And so if at the stage of evidence synthesis you say there isn't indirectness, well, it's unlikely to come up that much in discussion. And implicitly, what's going on is that any differences between trial and real-world populations shouldn't alter recommendations. So what assumptions are you making there? Well, there is an assumption there's a constant risk reduction across populations, that if you get a 20% reduction in mortality in the trial, you'll see the same in populations that aren't in the trial. And there's also an assumption that harm is constant across populations. So whatever the trial does in terms of rolling up risk-benefit, that will also be replicated. Or at least you're assuming that when you do extrapolate, that benefit remains greater than harm, and indeed, even if harm was higher, the absolute benefit might even be greater. So older people might be at more risk of harm, but their baseline risk of events is often higher, and so you might assume that it's all going to come out okay in the end. But a big assumption is there's no competing risk. So competing risks we all recognise. If you see someone who's dying of lung cancer and is going to die in 2 weeks, we all recognise there's no point giving them preventive treatments. But actually that applies further back. It applies to people with life expectancies potentially of several years if treatment benefits accrue over long periods. I'll skip over that one for time. So this is going to be looking at newly diagnosed type 2 diabetes. And so the trial which... there's more than one trial of this, but a really important trial in this context is UK-PDS. So UK-PDS, this is age, that's what the numbers are, and the blue bar is the inclusion criteria for UK-PDS. So it's relatively newly diagnosed people with type 2 diabetes aged between 27 and 65, and the red dot is the mean age of people in the study. The bottom one's just showing the median and then the interquartile range. So mean age is about 53, median's a little bit higher, but most people in this trial, half of them between 49 and 59. And if you compare that to newly diagnosed people with type 2 diabetes in Scotland, then that's what they look like. And so the median age at diagnosis, this is 2007, it's now actually a bit older than this, was 62. So that's just within the trial. But actually about 40-45% of people would be excluded from UK-PDS purely on the basis of age. Now I say that none of that matters, providing you're willing to make some assumptions, but you can also think, well, in what way are these people different? So this is now counting their comorbidities. So I'm not telling you that. We can go into specifics later if you want, but counting comorbidities, and unsurprisingly, younger people with newly diagnosed diabetes have got fewer comorbidities than older people. So some of these comorbidities will get you out of the trial anyway. So CKD, if you have chronic kidney disease, you're generally not in any diabetes trials, even though it's common in diabetes and it's particularly common in older people. But again, you're creating evidence in people who typically are likely to have relatively few comorbidities, and you're then applying it to older, frailer populations who already have more. So is it reasonable to make that assumption? Well, is there a constant relative risk reduction? I mean, this is one of these things that's actually rather hard to prove, but by and large, it's probably reasonable to accept that relative risk reduction might be constant. Is harm constant? Well, that's very unlikely to be true. Older people get more adverse drug reactions. If you're on more drugs, you get more adverse drug reactions. So older, sicker, on lots of drugs, just generally frail, harm is much more likely to be high. Will benefit continue to outweigh harms? I mean, to some extent, we think this comes down to how big the benefit is. If you've got a huge benefit, you've got to assume a really big change in harm for it not to work. But for this treatment, benefit is actually pretty small. So I usually say trivial, but I'll say small. So over 11 years of treatment, there's a 12% reduction for any diabetes-related endpoint, and almost all of those endpoints are non-blinding retinopathy. Absolute benefit may be greater. So it is possible that actually people with diabetes are more likely to get diabetes-related endpoints if they're older. But I don't know that's necessarily true in this case, and only if there's no competing risks. So what do you mean by competing risks? Okay, so you get a small benefit over 11 years of treatment. Well, what's your life expectancy? So, of course, it's very hard to know what life expectancy is in individuals. This is life expectancy data for women in England and Wales. Men, of course, looks rather worse than this. So the black line is mean life expectancy, the green line is the upper quartile, and the red line is the lower quartile. So, of course, the spread is, the true spread is quite wide across this. So if you're 80, you're newly diagnosed with type 2 diabetes, then your mean life expectancy is 10 years. It's roughly trial duration. And your expectation of benefit, if you had mean life expectancy, is, well, none really. I mean, none of, non-blinding retinopathy is not a particularly important outcome for a patient. Blindness would be, but there isn't any of that. If you're sick, so if you were down in the lower quartile, your mean life expectancy is less than 5 years. Sorry, it's about 5 years. I mean, even at 75, if you're sick, your mean life expectancy is less than trial duration. If you are healthy, so apart from your diabetes, you're actually pretty well, and you have you might expect at 80 to live 15 years or more. Well, actually, in that kind of context, I might be willing to believe that tighter glycemic control matters. because we know that the harms of having poor glycemic control accrue over a lifetime. But it all depends on what your lifetime is. If you're aged 50, actually I'm very willing to believe that even though the trials don't particularly show it over 11 years, I'm really willing to believe that glycemic control matters, because we know, for example, that the mean age of diagnosis of renal impairment in diabetes is 17 to 20 years after diagnosis. There's never going to be trials going that far. I'm willing to make that leap of faith, but should we be willing to make it up here? When giving people even reasonably tight glycemic control usually involves 2 drugs, or 3 drugs, or insulin, or other injectables. So, I mean, how might you take this forward? I mean, we don't think it's worth guideline development groups thinking about applicability too much, because there's lots of other things to do. But you might ask yourself the question when thinking about treatments, what is the treatment effect on a clearly important outcome? Is it an outcome that actually really matters to patients, or costs a lot if you want that perspective? Is it large enough over a short enough period of time to make applicability problems unlikely to be important? And if it's not, then actually you need to look at trial populations, not just by looking at trial populations, but by explicitly comparing them to real-world populations, which to my knowledge is not currently done in most guideline processes. And there's 3 examples for you. So ACE inhibitors in moderate to severe left ventricular systolic dysfunction, big effect, accrues over a year. You know, be unlikely to think about not doing that in most people. Glycemic control in new type 2 diabetes, I mean, I don't know. I mean, you know, there's no right answer here, and actually guideline development groups should be allowed to make their own decisions, but that's one that I struggle with. And then there's a whole pile of stuff in the middle. So blood pressure control in new type 2 diabetes has much bigger effects than glycemic control, and they happen over a shorter period. So in some people, that might well be, in some older people, limited life expectancy, that would be worth doing, but not necessarily in all of them. And none of this helps us decide when to stop treatment. So it's okay if you've got new type 2 diabetes. If you're aged 85 and you're pretty frail and you've had 10 years of treatment, tight treatment, and some torture as a result, when do you stop the drug? And at the moment we only stop it as you're about to die. But if you're in your last 2 years of life, which is where most healthcare costs arise, do you get anything by tightly controlling blood sugar when actually all the harms probably accrue over long periods of time? And we simply don't know. There isn't the evidence to help us there. So one final one, this is one for the perhaps people in the UK. So NICE currently have a guideline out for primary care prevention of ischemic heart disease, including lipid management. And they have, in the consultation, they're proposing that the threshold for giving a statin should drop from 20% to 10%. So 20% 10-year risk of coronary vascular disease, that's where our current guidelines say people should be offered a statin. They want to drop that to 10%. And so when you look at the trial populations are basically all under 74. And actually the mean ages, surprise, surprise, are all about 58 to 60. There is one trial which allows people in older age groups, but of course there's hardly anyone in the older age groups in that trial. So just because you've got the inclusion criteria lets people in doesn't mean to say they actually get let in. So that's trial populations. These are people who are eligible for primary prevention, so they don't have cardiovascular disease. If you apply the 10% threshold, then which is all based on a risk calculator, then in essence, everyone in the UK crosses that threshold at about 66 to 68, depending if you're a man or a woman. If you've got any risk factor at all, you cross it lower down. You cross at age 60 odd. So NICE is effectively saying that based on this evidence, or evidence in these populations, but actually evidence predominantly from this age group, everyone in this age group, that's about 68 to 84, should get a statin, and everyone in this age group, 85 plus, could get a statin. And is it reasonable to make whole population drugging recommendations based on that kind of extrapolation? Well, I don't know. I mean, I think, this is for guideline development groups to decide for themselves, but this is not an explicit discussion in the guideline. How big's the benefit? Well, NICE says that the benefit of statin primary care prevention is no meaningful benefit on total mortality, no meaningful benefit on cardiovascular mortality, no reduction in stroke, and there's a small benefit in non-fatal myocardial infarction, which is a meaningful measure. It's a meaningful outcome, but we're not talking about something with huge effects, but we're going to drug every single person above the age of 68. Is it sensible? I don't know. Been a lot of debate in the UK about the harms of statins. I mean, clearly they must have harms. Do they have harms enough to outweigh that small benefit when you extrapolate? Who knows? But it should be an explicit discussion. So the second issue that we've been doing some work on, which has mostly been done by health economists in Manchester, is thinking about absolute benefits. And so, absolute benefits, people, and certainly we wondered about using numbers needed to treat. So numbers needed to treat are tricky because they refer back to the trial population, and to make them work, if you want to look at other populations, then you have to have some way of calculating baseline risk. So the same 20% reduction in risk of death, the actual effect in that in individuals or in populations will vary greatly depending on what their baseline risk of death is. And so numbers needs to treat are highly unstable. Numbers needs to treat in a trial population which typically has got lower rates of outcomes compared to a true population may be misleading. And NNTs also kind of lead you into apple and oranges comparisons where you're trying to weigh off an NNT of X to prevent death versus an NNT of Y to prevent hospital admission. Not straightforward. And so QALYs, so quality adjusted life years, are one way of kind of rolling everything up into a single metric. They're not always available. They're not particularly good at transient harms. Clinicians on the whole don't like them because they're seen as being black box and no one's quite sure what they mean, but they do drive economic models, and economic models significantly drive many guidelines. So this is really just hinting at something that we're starting. So this is work in progress in Manchester. And they're particularly interested in how you better incorporate harm into economic models. So really two bits of work. One is can you create a framework for explicitly incorporating harms which would not necessarily be in trials? And the example they're currently working on is so depression and coronary heart disease, very common comorbidity. 20% of people with coronary heart disease have depression. First-line recommended drug treatment is an SSRI antidepressant. One of their risks is bleeding risk. And, of course, everyone with coronary heart disease is meant to be on an antiplatelet drug or an anticoagulant. And there's a significant drug-drug interaction there with harms. So they're doing some work on that. And, of course, this kind of modelling will only ever be a minority sport because most guideline recommendations are not based on new economic models. But if you're making a new economic model, how would you try and incorporate common harms? And that, again, is only likely to matter if treatment effects are relatively small. If the benefits are small, you don't need much of a harm, potentially, to tip you over the edge of saying it's no longer useful. The other thing we've been trying to do is trying to modify existing models to explore the impact of harm. And the example I'm going to show you is the NICE economic model for hypertension treatment. So the reason these models are done is for cost effectiveness. But one of the problems of cost effectiveness is if something is incredibly cheap, then even though it's of virtually no use in terms of benefit, it will be cost effective. And so this approach is saying, well, forget the cost, because costs vary. Drug costs may change, everything changes, cost effectiveness changes quite quickly. What are the absolute benefits of taking antihypertensive drugs? And so this is a model which is starting to be run at age 55, and it's looking at the cumulative absolute QALY gain for 4 types of antihypertensive. This is in men, because the models are distinguished by men and women. So these are diuretics, calcium channel blockers, ACE inhibitors, and beta blockers. And this is the model that led to beta blockers being downgraded from a first-line drug in the UK to a third or fourth-line drug. And over time, you get an increase in the expected benefit of treatment, which gets close to about 3/4 of a QALY if you live to 95, although most people don't live to 95. And in this model, there's no harm, except in the sense that there's harm as it's in the original trials. But the original trials are, of course, done in selected populations. If you just put some harm in, and this is putting in probably too much harm, if you put in a steady amount of harm from being on a drug, so in quality terms, that would probably come from quality of life reduction due to adverse drug effects. So if you put in a 0.02, that's 2% reduction in quality of life from being on the drugs, then you get this. And so I think this is almost certainly exaggerated, and we need to think more we are going to think carefully about how you might do this. But this is a way of doing a sensitivity analysis on benefit. So what you see is that initially, so at the point at which you're accumulating benefit, actually you accumulate harm. So benefit is cumulative over time, but actually harm, if you assume it's constant over time, you get to a point where actually you don't start getting absolute cumulative benefit until some point in the future. It's not immediate. And that does kind of make sense. So benefits accrue over long periods of time. Many drug side effects just happen straight away. So if you get ankle swelling from your calcium channel blocker, which many people do, it's completely trivial. It doesn't kill you, but actually it has significant effects on many people's quality of life. So, putting in this level of harm, which I think is too much, then actually the 55-year-old doesn't start getting benefit until they're in the mid-60s. And for beta blockers, they never do. So that's probably unrealistic. What's probably more realistic is thinking about, what's the likely level of harm at different ages or different levels of frailty? And to what extent do models then give you the same answer? If you get the same answer across plausible levels of harm, you'd be much more confident that this is a treatment that you really should be using, rather than if tiny amounts of assumed harm tip the balance. So I don't think that this is likely to make that much difference down at age 55, but actually if you were starting treatment up at age 80 or 85, it might make more difference. So I should say the benefits are greater in older people because their baseline risk is higher, although interestingly there's no benefit on mortality. So it may be that yes, you prevent cardiovascular events, the evidence of that's pretty good. There isn't evidence that you prolong life. Total mortality doesn't change. And that may be because we stop you having a heart attack and you die of your COPD. So, guidelines are great. Guidelines, I think, are also problematic clinically for me when treating people who are frail, treating people who've got multiple conditions. How might you improve them? So two ways which already happened, two ways we think could be made better. So there are some guidelines for common comorbidities, and I think the best example we've seen of that is the NICE guideline for the management of depression in people with a chronic physical problem. Really important comorbidity. Not a huge amount of evidence, but actually you can still write a guideline about it. You can maybe write guidelines for multimorbidity, and NICE has been tasked to write two such guidelines, but of course what does that mean? Because multimorbidity is all of life. So how do you write a guideline for all of life that isn't just motherhood and apple pie recommendations about always account for people's comorbidities? Well, okay, there's no evidence for that. Although I think there are ways of doing that kind of guideline. We do think that applicability ought to be more explicit in the way that guidelines are created, and one way of doing that is for selected situations to more explicitly compare trial populations and the population that you're writing recommendations for. That's all done in people's heads at the moment, we think. And I do think that we need to be better at trying to account for harms in modelling. Not because harms are usually bigger than benefits, but because even small amounts of harm may alter what you think you should be doing in people with reduced life expectancy. And actually, almost everyone I see are people with reduced life expectancy. The bulk of healthcare spending is in the last 2 years of life. Most people that we see are in the last 2 years of life. And then there's a tail of simpler morbidity. And so, just acknowledge, so two Scottish Government Applied Research Programme grants, so Living Well and DQIP, which is where a lot of this data comes from, each of those. And then the more recent work on applicability and harm is an NIHR-funded project. And in particular, Catherine and Alex are doing the health economics side. Thank you.
That was fantastic. Bang on time. Quick summary sounds like guidelines are great, but we have time for questions. So if you have a question, if you could make your way to a microphone and say who you are. So does anybody have a question or a comment for Bruce? Sure. Please, if you could just make your way to, I think that's the nearest one. And just remember to say who you are as well, please.
So thank you very much. I'm Gaston from Sweden, and I have a question about applicability. I didn't read, but I had some information about a NICE guideline about varicose veins, where they had very strict rules how to apply grade for indirectness. And it was like downgrade one step if the I-square was more than maybe 50, and 2 steps if it was more than 75. And we're not really used to work that way, and I wonder if you have any comments, or the grade group, how do they see upon that rule?
I mean, I could not comment on that specific point, but you need to ask NICE how they choose to apply that. I mean, I think what I would say, though, is that the way that applicability comes out in grade, though, is it's a downgrading of the evidence. Whereas for a clinician, the issue may be that the evidence is actually completely secure for the trial population, but very insecure for many of the people that I see. And so one of my issues with grade is that if grade says it's strong evidence, I know what that means. If grade downgrades the evidence, it could be downgraded for any number of reasons. And actually, when you come to apply that to individuals, it doesn't always feel right to me. You might be completely clear that in this 20% of the population who are in the trials, it's great. The treatment is clearly a benefit. But in the 80%, it's not. Mm-hmm. But it all kind of gets merged together into a downgraded quality of evidence. So I don't know that grade fully addresses the issue of applicability. And actually, it doesn't mean that it gets into discussions in the guideline development group. And so if you were saying, well, how might applicability work in guideline recommendations, it's whether you make more nuanced recommendations. In this population, we say you should do it. In this population, we say you could do it, but here are some things you might need to think about. The fear in that is that if you weaken recommendations in that way, you merely give clinicians the excuse to never do it. Yeah. So, and I mean, I don't have there's no solution to that fear. But at the moment, it doesn't help me to say, you should do this, but the evidence isn't great.
Okay, thank you for your comment.
Thank you. Any other comments or questions for Bruce? Please.
From Germany. What implications do you see for the designing research, and to what extent do you think guideline authors should address this?
So for research, I mean, guidelines are dependent on the evidence that exists. And so in some ways, you can only do what you can do with what's there. I mean, where do I think the gaps in the evidence are? I think there's no evidence on stopping, and actually that's often the decision you're faced with. The decision that someone's on 17 drugs and you think you might want to stop them. The second situation, so one potential solution for this is that you extend inclusion criteria for trials and you allow all these old people in. And the problem there is that, of course, if you have different effects in different populations, putting them all together in one trial doesn't help you. There is an argument, though, that if you're doing trials in younger, more cleaner populations to show treatment effect, at least sometimes you should then be repeating those trials in older populations and frailer populations to show that you still get the same treatment effect. But that's quite expensive. You would only ever do it, I think, if you were concerned about making that extrapolation. And for some treatments you won't be, and for some treatments you will be. So osteoporosis would be an example where it's quite hard to be old and not be on some kind of osteoporosis therapy in the UK. But there isn't that much evidence in those people for primary prevention. Secondary is a bit different.
Okay. Thank you very much, Bruce. Excellent. Thank you. Okay, our next speaker is going to give us an overview of the DECIDE project. So this is Dr. Andy Oxman. So Andy is a senior researcher in the Global Health Unit at the Norwegian Knowledge Centre for the Health Services in Oslo, Norway. And Andy is the scientific lead for the DECIDE project. And Andy has for a long time had a very strong interest with the problem of getting research evidence into practice, into policy, into commissioning decisions. Among other accolades, he's been very, very influential in the Cochrane collaboration, was instrumental in establishing GRADE, which we'll hear more about later, and has very, very strong links in the world of evidence-informed policymaking. Indeed, he's one of the world's leading lights in evidence-informed policymaking, with strong links with the World Health Organization in Africa, in Europe, and in North America. There is no better person to give an overview of the DECIDE project. Andy, please.
Thanks, Sean, and good morning. So I'm not going to go into much depth in anything that I'm going to say, but hopefully I'll whet your appetites, and you'll have many opportunities during the 3 days that we're together to go into more depth about the things that I'm just going to introduce you to. So as Sean pointed out, DECIDE is a 5-year project co-funded by the European Union, and we're 2/3 of the way through now. We've developed a number of different strategies to help people both to make recommendations or decisions, but focusing primarily on disseminating these. And we're now interested in evaluating these, and we're very grateful to all of you in advance for the feedback and the help you'll give us in terms of evaluation of what we've done. There's a large number of partners involved in this project from Italy, Finland, Germany, Spain, from the UK, including Scotland, so long, and from the Netherlands and the World Health Organization, all of whom are represented here. And the objective of the project is to improve the dissemination of evidence-based recommendations and evidence-informed decision-making by building on the work of the GRADE Working Group and developing and evaluating methods that address the targeted dissemination of guidelines and support evidence-informed decision-making. So some of you may not be familiar with the GRADE Working Group. Holger Schoenemann, the co-chair of the group, will say more about the GRADE Working Group after the break. It was established in 2000, about 14, 15 years ago, started out as a very small group, and over the past 10 or 15 years has developed an approach to making judgments about how sure we are about the evidence, primarily focusing on evidence for treatment effects, all types of interventions, and the strength of recommendations, how sure we are about recommendations. And Holger, I imagine, will say more about that when he speaks. Currently, there's around 80 organizations around the world that have both provided input into the development of this approach and are using the approach, including NICE and SIGN here in the UK, WHO, Cochrane, and a number of other large organizations. So what do we mean by targeted dissemination? We focused on 3 types of audiences. So patients and the public is one audience, the recipients of care, healthcare professionals of all types is the second, and policymakers and managers, people who make decisions for populations on behalf of a group of people. And we focused on 4 different types of decisions or recommendations. So treatment decisions, I'm using treatment very broadly here to include preventive, therapeutic, rehabilitative interventions. We've separated that from decisions about diagnostic tests because those are often more complex, and you'll be hearing more about that in a subsequent plenary, where we often don't have direct evidence about how different diagnostic tests have impacts on patient outcomes, things that are important to patients. So it's often indirect evidence where we have to make those judgments based on how accurate a test is and other information combined with that. Coverage decisions, those are decisions about if you're in a system with health insurance, which interventions are paid for by the health insurance, which aren't, or how much of them are paid for, or in a national health service, what's funded within the national health service, what's not paid for within the national health service. And then health system and public health decisions, and I should point out, particularly public health decisions where a decision is first made by some people on behalf of a population. So population decisions. So for example, if you make it mandatory to have vaccines or road and traffic interventions, things where individuals, then whatever choices they have to make those choices within a context of the decisions that have already been made for them on their behalf by either professionals or policymakers or managers. And we divided this work up. Those of you who are familiar with the different framework programs will be familiar with this idea of work packages, so bundles of work where different partners have taken the lead on these different packages. So the first work package is focused primarily on recommendations about treatments for healthcare professionals and how to disseminate this information to health professionals. Work Package 2 is focused primarily on coverage decisions, deciding what's paid for, what's not. Work Package 3 is focused on communicating this information to patients and the public who are making personal decisions. Work Package 4 has looked across all these different types of decisions for diagnostic tests. Work Package 5 has looked at decisions, health system and public health, or population health decisions. And then Work Package 6 is a toolkit that pulls all of this together to try and make it easier to use and more accessible for guideline developers, policymakers, health technology assessment agencies, systematic review authors, and others who might use these resources. So all of these strategies share a common feature that they all are tailored to a particular type of decision and a particular target audience, and they use interactive presentations that make it easier for the producer of a recommendation or a review to tailor the information to particular audiences, and for the people in the audiences to interact with that information, to start out at a top layer, and then to dig in if they want to looking for more information. So almost all of these use layered presentations, and I'll show you just quickly a few examples, and you'll hear more about those as we go along. Interactive summary of findings. So these are presentations of the key outcomes for any intervention that's being considered or option. Interactive evidence to decision frameworks are a structured approach to making the judgments that are often very difficult, as Bruce was just pointing out. Plain language glossaries or plain language explanations of some of the terms that are used when we're doing this work that sometimes confuse people. And the guideline development tool, as I said, that's from Work Package 6, will pull all of this together. And all of this work has had pretty similar methods in the development. So we've started out with the grade working groups approach. We've reviewed the relevant literature for the different tools that we've been working on. In some cases, we've done surveys, for example, of policymakers looking at their perspective on how these decisions are made. We've done brainstorming repeatedly to find solutions based on the input that we've got at each stage. We've gotten feedback from stakeholders, including advisory groups for these different tools we've been developing. We've applied it to examples, both fictitious examples and in real guideline panels or policy decisions. And we've done a lot of user testing, which is a qualitative approach to getting feedback of how users experience these different resources and their feedback on how to improve them, as well as what the problems are with them. And then we're in a phase now where we'll start testing some of these resources in trials, doing comparative evaluations of whether they're achieving, in particular, whether they're achieving better understanding and better decisions or choices that people have to make. So a few quick examples of the layered presentations. This first one is from MAGIC, which is a collaboration between Decide and a project in Norway, where Per Vanvik is the lead, and we'll speak about this afternoon. Starting out with a list of recommendations and then allowing you to dig in deeper, looking for the information, starting with the justification, perhaps a summary of findings, and digging in deeper and getting more information depending on your interests and needs. Another example of a layered presentation that can be generated from the interactive evidence to decision framework, again, where you can list the recommendations so you quickly get the bottom line. It may be with a short justification or without that. And then tabs where you can find the particular information that you're interested in. For example, the more detailed practical recommendation in plain language, or the justification with more details, or the more detailed justification, or the summary of findings underlying the recommendation. Here's another example from a WHO guideline that was developed using the evidence to decision framework, where, again, on the surface, in this case, there's a series of options, different health professionals or health workers who can deliver different types of care and the different types of care. And then you can focus in, looking at this from different perspectives, the particular types of care you're interested in, or the particular types of health workers you're interested in. Quickly get a gist, scroll over to get an explanation, or click on it to get a summary. And then if you want, dig in and go to the full description of the guideline. Or for patients, a group based particularly here in Scotland, the Work Package 3 has been talking to dozens of patients and people in the public, looking at how they would like this information presented. And again, often beginning with the top layer being the recommendation, in this case in a way that's clear to patients or the public, the justification, questions that they've been asking, or who's this for and what does it mean for you, where you can present this information in ways that are clear and helpful to patients or the public. The interactive summary of findings table is a way of presenting the main findings of the intervention or comparisons that you're interested in, and it allows the producer to choose how much or how little information to present initially, and then the users can look at more information or change what's presented. So, for example, for a patient or public audience, you might start out with just a plain language summary, which is a qualitative statement in a structured way based on the quality of the evidence and the size of the effect, and the certainty of that evidence or quality of the evidence and the main outcomes. And you could hide some of these outcomes or show all of the outcomes to begin with, depending on which outcomes most patients are most likely to be interested in. Or alternatively, you could start out with a presentation of a quantitative presentation showing the absolute effects, which is what we want to look at when we're making decisions, and the difference in a very simple presentation, again with the options of expanding or closing the different outcomes and adding other columns. If someone's interested in looking at the relative effects, they can add those, or the plain language summary. They can flip this and get the explanation in text, or click here, and they'll get a slideshow. They can get a visual presentation, so it allows you, in this case, we're looking at dabigatran versus warfarin, so a new anticoagulant versus an older one for atrial fibrillation. And you can quickly see the benefits line up here. So out of 1,000 people, our best estimate is 8 fewer deaths, 11 fewer strokes, 4 fewer major bleeds, but you have 4 more heart attacks, and you can weigh that up. And so it's a quick visual presentation that helps you to look at the information in a way that helps you to make this judgment about the balance between the benefits and the harms. And you can also, in interactions with patients or online, patients can walk through single outcomes to get a clear explanation of what this means. Typically, you would do this once or twice to understand what's going on, and it's essentially a slideshow that shows you exactly, explains what this means for each of the outcomes. And a similar table is being developed for diagnostic tests with different ways of presenting this, and this will be discussed in a workshop, and I'm not sure, perhaps in the plenary. So here it's showing you the pre-test likelihood of having a disease, and in both the previous one I showed you for interventions and this one for diagnostic interventions, you can have different levels of probability of the disease beforehand or different baseline risks for different outcomes, and look at those for different types of populations. And then this shows you with a positive test the likelihood of having the disease, and with a negative test is one way. And then it shows you out of 1,000 people how they would end up being categorized. The interactive evidence to decision framework is a structured framework that helps people to think through the factors that are driving a recommendation or a decision in a structured way, to consider the research evidence that's available to inform each of those judgments, and to be explicit about any additional considerations that they take into account, such as assumptions. For example, if you're making assumptions about extrapolating the evidence to patients with comorbidities or multiple morbidities, you could explain that if there's no direct evidence. Or it may be other types of evidence, such as local data that's being used for your baseline risk might go there. And these are developed so that there's a different template for each of the types of decisions that I described, where for some decisions these criteria will be different than they are for others. And certainly at the end, the recommendation or decision, the types of options you have will be different. If you're making a decision about whether to cover something to pay for it or not, you really can't make a weak decision to pay for it or not. You have to make a decision, but there may be other options, such as you would only pay for it with evidence development, or you would only pay for it with price negotiation, or you would only pay for it under restricted circumstances. So there'll be a different set of options depending on the type of decision or recommendation that will be made, and differences in how these criteria apply, depending both on the type of decision but also the perspective. And so in the workshops where we'll be discussing this, we'll talk a bit about the perspective that's taken, something that many guideline panels have not been clear about when they've been making recommendations, and it can make a very important difference in the recommendation that you make if you're taking a population perspective where you have to take into account the opportunity cost, the resources that are being used, that could be used for other things in the health system. Whereas if you're taking an individual patient perspective, you're primarily interested in the perspective of individual patients and the out-of-pocket costs, and not the cost of the health system. And that can lead to very different types of recommendations, as well as there may be other differences for other criteria. And I should flag here, since Bruce made a great presentation focusing on multiple morbidity and comorbidity, one way of dealing with that issue would be a subgroup considerations. And so in these frameworks, you can specify specific subgroups of interest, and maybe one or more comorbidities or multiple morbidities or age groups or drug interaction groups, where you can explicitly consider those subgroups, and when it's appropriate, make separate recommendations for those separate subgroups, looking at the evidence and the assumptions or additional considerations that you're taking into account for each of those subgroups. And again, for diagnostic tests, it's very similar, but because we're dealing with indirect evidence, there's additional complexities that have to be built into this. So you have to consider the evidence of test accuracy and your confidence in that. In addition, you have to consider what the management decisions are and how effective those management strategies are, and how good the link is between the results of a test and the management decisions that are made. And so this is a structure for making those very difficult judgments more systematically and transparently, they can make the work of panels much easier and make it much clearer to the target audiences how these judgments were made and how the recommendation or decision was reached. Then the glossary of evaluation terms is, again, a collaborative project with several other projects where these are plain language explanations. So these are very short, definitions. These are very short, 130 characters, so you can do a scroll over and get a very quick definition of a term in plain language, and then you can click and link to a longer explanation, most often with examples. It's being developed collaboratively so that although there are a lot of glossaries out there now, most of them don't use plain language, and although there's been some very good collaboration across organizations, one of the aims here is to collaborate across organizations. There's over 20 now interested in collaborating so that we can benefit from each other's work, and we can also start with similar starting points and adapt that to particular audiences or translate it to different languages and share some of the work and evaluation of this. It also includes links to additional resources to help people to understand more difficult concepts, for example, what a confidence interval is and what it means to people making decisions. And it will be open access so that anybody can use this. It will be accessible as directly on the web, or people can embed it in their own web page as an add-in or add-on on their web page to look up terms or link to the explanations, or to have highlighting hyperlinks to the definitions in documents such as guidelines. And then lastly, the guideline development tool you'll be hearing more about. It will pull all of these resources together and is designed to help guideline developers, in some cases review authors and health technology assessment agencies, to make these judgments and put together this evidence in ways that help other people to make these judgments and decisions. So it's perhaps clear already from what I said that there's been a lot of input into all of this work by a large number of people. So each of the work packages has an advisory group with about 30 to 50 stakeholders with different types of backgrounds and expertise and experience relevant to each of the target audiences or types of decisions. We've done surveys, as I pointed out, with a number of different groups, including policymakers, interviews with a large number of people, particularly Work Package 3, for example, has done around 100 interviews with patients and members of the public to get a better sense of their understanding of recommendations and guidelines and what their problems are and potential solutions. And in-depth interviews done by the Work Package 4, focusing on diagnostic tests with guideline developers, looking at what's already being done and challenges, problems with that, potential ways of improving how this is being done. All of the different tools that I've mentioned now are being user-tested, as I point out, with dozens of different types of people from the different target audiences, and the different types of decisions. So these are qualitative, structured interviews where people walk through using one of these and describe what they're doing as they go along and provide information about how they're experiencing it, problems they have, and then looking for potential fixes for those problems. And it's been presented at a large number of conferences and workshops already, including many GIN conferences, Cochrane, and others. And, of course, we're all here now for these 3 days, and we're looking forward to getting lots of input from all of you. We hope at the workshops that you'll all be providing feedback, suggestions, as well as using the postcards that you've been given and the various evaluation forms you'll be given, and speaking up at these sessions when you have comments and suggestions, as well as questions. So that's it. We've got 7 minutes to go. Should we take questions or?
So we have time for questions, comments, and his presentation. Anybody? Please. If you could please remember to say who you are as well, that'd be great.
Yeah. I was wondering about the pediatric component of the shared decision making, because I tried to communicate a couple of times with the members of the side about that and didn't get really a good grasp where it reached and how it is developing.
Thank you. So, in particular, the work package 1 that's focused on clinicians and work package 3 is focused on patients have been very interested in shared decision making and decision aids. And so one presentation here is an interactive approach for helping patients to make decisions in a patient clinician consultation. And I'm pretty sure Pierre, where's Pierre, will be showing you some of that. Is that right?
Is that pediatric?
Yeah. Pediatric. Well, as far as I know, nobody's focused specifically on testing this directly with adolescents or children who are old enough to make their own decisions. For parents, it would be a very similar approach to what you're doing with any other type of decision. But we haven't, as far as I know, tested this out specifically with adolescents or pediatric decisions. I'm not aware of any specific tests with that group.
I just had one. So Andy's quite correct with regard to, say, the frameworks, but the patient public work package, although it hasn't done any formal testing with children, it has done some of the interview work with younger people. So they were 16 or less. So there's a little bit of work on the sorts of things that they might want from guideline-derived products to help them with decisions. So it's not the framework approach, but there is at least a little bit in that project, in that part of the project where we did expand the remit, if you like, with regard to who we should talk to, and we did include people who are at the young end, not just and the older end as well. So it was a wide range of people. So we have a little bit, but not perhaps as much as we would like.
But you're welcome to get involved and do that testing. Good.
Any other questions or comments? I had one, and it's to do with the feedback. So we keep talking about feedback. We want to have lots of comments, lots of ideas, lots of suggestions. So what I wanted to ask Andy then was, everybody will go into workshops, everybody will go into the plenaries. If we'll have specific questions for them, specific evaluations, forms for them. Is there anything general, sort of a general question that you would like people to come to these sessions or to workshops with that you would like answered? What do you want people to bring with them as a general question?
Well, so the answer is no. There isn't a specific question. I think clearly we want to hear what you like, and we want to hear what you think is problematic, and we want to hear your suggestions for fixing things. For some of the workshops, there will be structured feedback forms. And maybe one thing we could do, since there's time, is just get each of the groups to stand up so people know who to grab if they're interested. Should we do that? So work package 1, can the people working with work package 1 stand up? These are people you want to grab if you're interested in communicating this information, disseminating it to patients and the public. Okay? And then some people weren't standing up because there's more of you than that. Work package 2 is focused primarily on coverage decisions. This is, and they all speak with a lovely Italian accent. Work package 3 is focused on clinicians, people in work. Sorry, patients. Sorry. Did I screw it up when I? Okay, patients. Sorry, patients. Okay, and then work package 4 is diagnostic tests. And work package 5 are health system and public health decisions. And it's me. And work package 6 is the GDT. Over. So that gives you a sense of who you want to grab if you have specific input or questions, or you're interested in testing these things out with, in particular ways. You know who to grab now. I think probably we should go to coffee now.
Yeah. So have a coffee break now, 30 minutes. If you could all come back just a few minutes before 11:45, and then we'll start the next session bang on time. Thank you very much.
Oh, yeah, that's cool. You can actually generate that.
Yeah, no, that was cool.
Hello, everybody. Good evening, everybody. We're going to start. We are 2 minutes late. Well, welcome to this. Well, can you hear me well at the back? Yeah. So welcome to this session about communicating evidence-based recommendations to health professionals. That's the work we have been doing in Work Package 1. And although I'm the chair this time, I will talk briefly 10 minutes about what's been the progress in Work Package 1. And then we have two great speakers, Per Van Beek from Work Package 1 will tell us more things about Work Package 1 implementation of the strategies, and also Melissa Brouwers from McMaster University. So given that it's been other talks that have talked about the methodology, I will refrain myself and I won't say anything about methods. We've used common methods across work packages, iterative, decide methods. And if you want any information about those methods, more detail in a protocol published recently in Implementation Science. So in our work package, there were 3 issues that we concentrated on, that we found out that our strategies or formats developed, Our strategies or formats that we developed had 3 main characteristics. So our strategies needed, like everybody else, but they had to be needed to be based on grade. They should be organized as multi-layer, that already is being said, but yes, different needs, different layers. Within a same user, there might be different needs, and there's variation across users. And also very important, they need to be electronic. We are addressing static presentation, of course, as PDF or HTML, but also very important to go into interactive. And why? Because it's very important for users to move, or to hide excessive information, and for users to be able to move from layer to layer. So all types of devices will have to be able to provide the information at the point of care. And these are our 3 main strategies: top layer format, a decision aid template, and an evidence to recommendation framework. The first 2 strategies, laid out in blue, we work together in a partnership with the MAGIC program that you've heard about already during the morning, and you will hear more about during today in the conference. So, top layer. I will go briefly over it because already Andy talked about it. But the process were as follows. We developed a prototype, an initial prototype, and what it was about the top layer. Well, basically, we defined the top layer of what clinicians would want to see next to understand the recommendation. So it's like the main entrance to the guideline. Because most users, they stop just at the recommendation level, but once they want to inquire about the recommendation, what would be the most useful information they need after they click on that recommendation? And we work on 2 different issues. One, and if we follow the onion approach from less complex to more complex, a justification, explaining which factors were driving the recommendation. But also, if they wanted more information, another aspect that we call the key information, we would provide them succinct information about the main grade factors. So the balance of benefits and harms, the certainty of the confidence of the effects, values and preferences, resource considerations, or other factors that may bear on the recommendation. So this is our first template at the beginning of the second year. So as you can see, you have a set of recommendations, the patient population, the strength, and the wording per patient population. In this case, is a patient with atrial fibrillation and different risk of stroke. So if people click at the recommendation, we provided them with a rationale explaining the justification of the recommendation, which factors drove the recommendation. And also, at any point in time given, there was a menu of different options to dig in deeper into the information. So go to the key information section, go to the summary of findings table, etc. So if they wanted to dig in further, they could dig into this key information section. As you can see, we have there the benefits, harms, the confidence in the effect, the preference and values, resource use, etc. And again, also having access through a menu to the different layers at any given time point. As you can see, there are many choices involved here in the design. So colors, font, quantity of information. For example, here we provide the results per 1,000 patients, but we provide confidence intervals. So different choices, many choices involved in designing with not so much evidence or very little evidence to back up those choices. Well, some of those choices work, some do not work. We did 35 individual user tests across 7 countries in 3 iterations, and they liked the interactive multi-layer approach clearly. However, at the beginning, they thought it was too crowded, too complex, too much information, too much methodological information. For example, the confidence interval at the top layer, people didn't find them useful, even confusing. Symbols were confusing, colors were promising, and we did subsequent iterations, and refined templates received improved feedback, and Per will show you with more detail. But basically, this is the final presentation at the moment, and Andy has already gone through it, so just skim through it. The recommendation, if you want more information, dig into the rationale. If you want more information, you can go and dig into the gist of the different factors that bear on the recommendation, the key information section, as we call it. And also, again, too, if you want even more information, you can go to the summary of findings table. And here is not available in this presentation, but also there could be an access to the evidence to decision framework with all the panel decisions for the different criteria and the judgments too. That could be made accessible also in deeper layers for those, very few, but some users that might need to access that information, might want to check. We're doing trials and surveys with the top layer that are ongoing, basically, at the moment still. We don't have results. We have a randomized trial comparing evidence summaries with and without evidence-based recommendations. And thank God, users want recommendations. Imagine they do. Especially in the situation with low-quality evidence. And another survey, an RCT that's going on, is also to determine physicians' understanding, attitudes, and preferences concerning this new presentation format of the top layer. We've also gone to the decision aids field. And why? Well, basically because most recommendations, or the majority, they turn out to be weak. And as by the definition of grade, weak recommendations for patients in these cases, in the case of patients, the majority of people in this situation would want the recommended course of action, but many would not. And for clinicians, they have to be prepared to help patients to make a decision that is consistent with their own values. And that's why we think that it's crucial to link shared decision-making and guidelines in this context of an excessive number of weak recommendations out there and uncertainty. So we are bringing decision aids and link it to grade guidelines. And also, we are moving away from the concept of decision aids that people take away home, that they are cumbersome and they just read them on their own. We don't want this type of decision aids. And we are moving into an area of a decision aid to create a conversation at the point of care between the physician and the patient, not for the patient to go away and read the decision aid. So we're trying to get the best of both worlds, of trustworthy guidelines, so the evolution in guidelines that we believe is great, the accountability of great, the transparency, etc., and also the evolution in the decision aids. So moving from classical decision aids to more interactive decision aids to create a conversation between patient and physician. And we are also hopeful that the technology will help us also to be able to produce a semi-automatic, so a template that could help guideline groups to create in a semi-automatic way decision aids to be used at the point of care for weak recommendations. So we are providing evidence to clinicians in Work Package 1, as you can see in the top layer. Work Package 3 is also more focusing on providing the evidence to patients. We will be talking here about the interface of that. So an interface where clinicians and patients are talking and using a common tool. We've developed initially, our first objective was to develop an initial prototype, so we did, and I won't go into details. So we did decide methodology, iterative, meetings, etc., design. And right now we are user testing it in real clinical encounters for different conditions. So we are user testing it, and at some point we will arrive to a final decision aid template that we will very soon, we hope, test the feasibility in a guideline authoring tool. We're going to try this first in the Magic app, and then we're going to implement it in the GDT2 as soon as we see how feasible it is and how it works. And in the future, we'll also do RCTs and other type of studies with these decision aids in real guidelines too. So where can physicians access this tool? So as you can see in the top layer, there could be also another tab, not just for the justification or the keying for the summary findings, but another tab for weak recommendations that in some instances panels might have developed decision aids. And I won't click into here because Per will show you what they look like in a minute. So those are two of the main strategies we've worked, and the other one is the evidence to decision frameworks, which I will just say briefly a couple of things because there's going to be two main plenaries about these frameworks, and you will have enough time there to get to know them. So these frameworks are actually frameworks to help guideline panels and decision makers to move from evidence to a recommendation or a decision in an explicit and structured manner. They build on previous work from GRADE, and we've developed, together with other work packages, different frameworks for different types of decisions. And now also these frameworks have been developed interactive, and they will be integrated into the respective guideline development tools. And at the moment, we're also working, we're excited, working on a series of papers that explain all these frameworks, for the development and the different types of frameworks in a journal that will be published hopefully at the end of the year. This is what the electronic framework looks like. It has three main sections, which are the question and the background, the different criteria that bear on the recommendation, and the conclusions that take into account of those conclusions, take into account the different judgments across the criteria. Okay, so our next steps are as follows. There's further refinement of the top layer through more user testing and implementation in guidelines and real guidelines. We have to keep on, as I said, user testing, the decision aid template and implement it in GDTs. And also, once this is done, testing in RCTs and other designs. And regarding the evidence to decision framework, further evaluation in guideline panels and compare it with standard, less structured processes too. Okay, so after this brief introduction to what have we been doing in Work Package 1, I'm going to present our first speaker, which is Per from Work Package 1. A hospital physician over the last 10 years, obsessed literally, with making best current available evidence at the point of care. Over the past 4 years, this obsession has resulted in MAGIC and an initiative to develop, also disseminate and update guidelines that you will hear more about during the conference and his presentation. He will talk about the work in Work Package 1 and how it's being implemented at the moment in real guidelines. Thank you.
Okay, see if I can do this. What? Okay, yes. So a pleasure to be here. Thanks for inviting me to talk about how to relate clinical decisions to evidence. It's obviously about our patients and clinicians, in this case, acute physician from the US. And during this talk, I hope you'll understand this is also about how these two could dance together. Takes two to tango, and that's going to be a key message from this talk. This work is a collaboration between DECIDE Work Package 1 and our MAGIC Research and Innovation Program, so I'm going to tell you a little bit more about that later. Also with funding from Norway, for instance, our local hospital trust, Sykehuset Innlandet in Norway. So I'm going to talk about clinical questions, looking at this from the point of care perspective. Why bother? Short repetition of evidence-based practice and trustworthy guidelines, although I think this is familiar to most of you. Current problems with guidelines, how we've now implemented the DECIDE strategies in Norway in the real-life guideline, and what we learned so far. Touching on some remaining challenges and solutions before Melissa will tell you more about a big framework for that. So I think it's worthwhile to remember for those of us that actually do meet patients and our clinicians at the point of care, it's extremely difficult, I'd say. It's, as said here in the paper from JAMA, fundamentally interpretative, that's a difficult word, interruptive, multitasking, collaborative, distributed, opportunistic, and reactive. I do 80% research. For every week I'm in my office, things get simpler and simpler, and I think it's lots of fun to create guidelines. Once I'm out in the clinic, walking around in the bed wards, I realize how difficult life is. And that's a challenge we have when we create clinical practice guidelines. So I'm going to tell you a story about a patient I've called Anne. She was admitted to our hospital with abdominal pain. She's a 53-year-old account manager. She has the diagnosis of diabetes type 2, hyperlipidemia, and hypertension. Now, Bruce Guthrie told you about people with these kind of risk factors, and she has high cardiovascular risk for sure. She's already on 3 drugs, aspirin, statins, and ACE inhibitor. But she's developed a stomach pain. So she comes into our hospital. We thought it might be a peptic ulcer, a bleed from the stomach, so we did an endoscopy, which turned out to be normal. So good news, no peptic ulcer, but she still has her abdominal complaints. It's what we call functional dyspepsia. Now, Anne, coming back from the endoscopy, actually asked me the question, well, I never figured out why I am on all these drugs. My GP told me I should take them, but do I really need to take them, and in particular aspirin? I think that's the cause of my stomach complaints. I told her, you don't have a peptic ulcer. She said it might still be due to this aspirin, and what is it actually good for? So this is a clinical question arising at the point of care in busy practice. And what do we do in those situations? Where do we look for an answer? And what information resources are out there? And how do we actually communicate with Anne once we find the answer? And there's a systematic review published this winter in JAMA Internal Medicine of all studies looking into clinical questions raised by clinicians at the point of care. And it shows pretty consistent findings from 7,000 questions. Turns out that we, as in this case doctors, clinicians, only pursue 1 in every 2 questions. And the problem is, for every second patient we see, an important new question emerges. And in terms of patient safety and quality in healthcare, I think this is, to some extent, the elephant in the room. If you come into the hospital and the doctor or the physician, clinician has a new important question that concerns your diagnosis and treatment, he's only able to pursue half of them. Okay, so let's remember this. This is a challenge we have when we create guidelines. Because evidence-based practice was created to provide trustworthy answers to clinical questions. And I teach evidence-based practice through these steps. So from perhaps a pretty imprecise question at the top, does Anne really need to take aspirin? To a focused question in the PICO format, what is in people at high cardiovascular risk, what is the effect of taking aspirin versus not taking aspirin on patient-important outcomes like death, strokes, myocardial infarctions, and bleeds. Then you go out to search for the best evidence. Then you do critical appraisal of the evidence. Then you could integrate that evidence with clinical expertise, patient preferences, and perhaps change practice. Now, this is absolutely, totally not feasible for busy clinicians. And it's been touched on by several people that we actually, I think, agree that we need some help. So that means we have to search for the best guidelines out there, find the recommendations. We might still have to think about whether we can trust and use those recommendations, and I'll come back to that in a minute. But at the same time, and this is an important point following up on Bruce Guthrie's talk, we're not able to make recommendations for each and every one of our patients. We make recommendations for a group of patients. And there's still a need for clinicians to make judgments, take into account all their knowledge about these patients' multimorbidity, polypharmacy, when you apply these recommendations. Because we can only come so far when we create recommendations in guidelines. Then we might still have to change practice. And this is where the dance comes into play. I think we need to think about how we could share this information with patients when, for instance, we look at guidelines to facilitate shared decision-making at the point of care. So how do we get to the evidence in Norway? Well, we're actually quite lucky. We have something called the Norwegian Electronic Health Library. We could do a pyramid search. I'll show you in a minute. It's based on the 6S model from Brian Haynes and colleagues at McMaster, where you would trawl to different information resources and get it presented in a pyramid. So if I put two of the words from my PICO question, primary prophylaxis and aspirin, into the search field, clinicians in Norway will get, during a few seconds, answers in different information resources. And in green at the top are the recommendations. In Norway, we have access to up-to-date and best practice. Then below, you have the pre-appraised systematic reviews that are relevant. Then you have systematic reviews, and down in red, it's dangerous, it's PubMed, it's all the unfiltered studies, where of many you cannot trust. So let's have a look in up-to-date, because this actually makes it possible to answer a question within 2 minutes in my practice, and that's where I looked in this particular case with Anne. Before that, I think a key challenge we have in Norway and across countries is to make sure we get to the national or even locally contextualized guidelines. 2 reasons why we don't have any national or local guidelines at this level in Norway. First, they don't work as tools for decision support. Second, we struggle with getting the content right. So trustworthy guideline, not that many in Norway. But that's what we want to aim for, getting that on the top, the national or even local guidelines. Let's have a look at what UpToDate says and what's the answer to the question. Here it says, and this is the answer to the question actually. In many adults, the benefits of aspirin exceed the risks, principally bleeding. For individuals aged more than 50 years without excess bleeding risk, we suggest low-dose aspirin, 75 to 100 milligrams, grade 2B. Now is where I'd like to take a minute and ask you to discuss with your neighbor what a grade 2B recommendation means. I know many of you are familiar with this, but just to check if anyone got it right, discuss with your neighbor, a couple of minutes, what does a grade 2B recommendation mean? How do you interpret this recommendation? Go ahead. Oops, thank you. Just wanted to scare you a little bit. That was what I was not supposed to do. Sorry about that. So anyone, could you tell us what a grade 2B recommendation means? Shout it out, please. If anyone feels confident what this means. Anyone? Yeah? Go ahead.
It's a weak recommendation, moderate level of evidence.
Right. So UpToDate uses a letter and number system that reflects, in this case, is a weak recommendation, moderate quality evidence. Part of our research in Work Package 1 shows that this is totally confusing to clinicians. They don't get it. So we have to do better when we convey the methodological concepts of strong and weak recommendations, for instance. I'll come back to that. Another issue here is a colleague of mine who's 56 years old said basically, aspirin to everyone above 50, are you kidding me? And that's not the way we hope this recommendation should be understood. Okay, national guidelines in Norway, what do they say? This is the Norwegian equivalent to UpToDate, provides a recommendation, translated to Scottish. Aspirin, 75 milligrams, recommended only to persons with high to very high cardiovascular risk, and for women only to those older than 65 years old. So Anne is actually off the hook. But there's a discrepancy here between what UpToDate says and our Norwegian guidelines. This is based on a national guideline from the Health Directorate from 2009. Now, we have talked about standards for trustworthy guidelines, and according to these standards, many of us struggle to make sure we do create trustworthy recommendations. So this is a study showing that basically guidelines at the National Guideline Clearinghouse only met about 40% of the criteria. We all agree on these standards, both from the Institute of Medicine and the GIN community agrees basically on what the standard should be for trustworthy guidelines. And there's one important point here, which Bruce Guthrie was talking about, and I'll talk about, is the balance between benefits and harms. And how do we get that to clinicians and patients? So imagine you found a trustworthy guideline for Anne. This is a guideline published in CHEST 2012. I spent 2 years of my life on this particular guideline, just updating it. There were 128 people working across 600 recommendations, spending 2 years just to update our guidelines. And I think it's fair to say we do follow the grade system and provide trustworthy recommendations. The problem is they do not work at the point of care. So you have to scroll down 60 pages and you'll actually find the recommendation that you also would find in UpToDate. If you want to look at the evidence profile, it's in the vertical format. You have to do something weird with your computer. And this just was itching a lot. When I was a guideline editor, this was itching a lot because I thought this is not good enough. We have to do better. So to what extent are these guidelines created in the most efficient manner? Are they available, useful, understandable for clinicians at the point of care? Can we get our guidelines into the electronic medical records, which is where most of us now work? Could we get them into EBM textbooks like this Norwegian resource you just looked at? Could we adapt a guideline like this for national, local purposes? Can we keep them up to date? Once there's new evidence about some anticoagulant, could we update very quickly? And could we facilitate shared decision making? This is very much of the background both for the DECIDE project and for the MAGIC program. We need to do better. And you heard about DECIDE and Work Package 1, where we're addressing how to do this better for clinicians. GDT will implement all DECIDE dissemination strategies. And now I'll tell you what we're doing in MAGIC. So this is a research innovation program in collaboration with DECIDE, coming up with maybe some alternative solutions and additional functionalities. And this is what we do. If you're a guideline panel, you'll create a guideline straight into a database through our authoring tool and publication platform called the MAGIC app. The good thing about GRADE is that you can do this regardless of whether you're a physician or nurse or whatever profession you belong to. In any clinical topic, you will create structured content in the database. And once the content is structured like this, you could automatically publish guidelines in the multi-layered formats. You could integrate the guidelines in the electronic medical record, and you could adapt to national local context, and you could create decision aids. We've done this in Norway also through a real-life guideline initiative. And this guideline is now ready for dynamic updating. So once there's new evidence, you could just go straight into the authoring tool and publish updated recommendations quickly. So what we did was to take this big chunk of paper, 600 recommendations, and adapt, transform into a national guideline in these new formats. And there are two people I want to honor. That's Lynn Brandt, who's here, and Annette Christiansen, who did a huge piece of work in Work Package 1. And we just published a couple of papers in CHEST, which shows us that it is actually feasible to create and publish guidelines in these formats. But it also shows us that it's very difficult to write this short, succinct information. So it's not easy to create these top layers that you've been looking at. The other part we've been doing is adaptation, which can be very painful if you tell people. And that's a story I could tell to someone if they're interested later. So you've now seen several examples of how this guideline looks like, so I'm going to be very quick. This is the recommendation for Anne. The Norwegian panel suggests use of aspirin to patients like Anne at high cardiovascular risk. You could click and you could look at the effects for Anne in this key information section. You could read the rationale, or you could look at practical advice with the risk scores. You could look at the evidence profile. Different ways of showing the same information, making it possible for you to engage patients in shared decision making. But this is where we thought we had to do better. So now I'm going to show you the decision aids that Anne actually was looking at to make a well-informed decision herself. Before that, you could also drill down all the way down to the original references and read them full text if you want. Before you will look at the decision aids, these are our insights so far, both from the user testing, from the trial surveys, and then real-life observations when guidelines are published in this format. As Pablo mentioned, they seem to be pretty well accepted and considered useful by clinicians. They're even preferred over the up-to-date format in our Click-It trial. We have a huge challenge, I'd say, in conceptual understanding. How do we convey to clinicians what do we mean by strong, weak recommendations, uncertainty in the effect estimates, etc.? I think this is one of the main challenges we have when we publish guidelines in these formats. People become confused, and they need to increase their competence in methodology. Definitely they need further improvements, but these guidelines and these formats are ready to be applied for your organizations through GDT or through our tool, or I'm sure there will be more tools. The other key message is optimist formats are not enough, because they might still not be possible to find, navigate, and use. And this is what we're doing right now in Norway. We're testing them at the point of care. So one story from last week. These are two resident physicians at my hospital. I barged into the office, and they had a question about treatment of a patient with pneumonia, bedridden, and the question was, should this patient get prophylaxis or not? This is like a typical question for internal medicine docs. I told them about this new guideline, and that's problem number one. We published it 6 months ago. Basically, very few have heard about it yet. That's problem number one. Then they logged on, and they were waiting, and they were waiting. And after 3 minutes, there was still no answer, and they couldn't drill down into the guideline because Internet Explorer 8 is just way too slow and old. So this is a showstopper. This is an angry doc. She was really not happy. And it's really a showstopper for us. So solutions, obviously people have smartphones. I gave her my new tablet computer, put it in her pocket, and said, why don't you have a look at the tablet? And then you could get the answer in 17 seconds. Another key message is people need offline access because they don't have Wi-Fi all the way, all over the hospital. So there are problems and solutions, and we're going to address them one by one. Share it, finally. How could we share this with our patients? And Thomas Agoritsas is here, Anja is coming, and you could talk to them and attend the workshop on Wednesday to learn more. This is what we did with Anne. I could sit down and I would ask her, now you have this choice of taking aspirin or not. What aspect of your medication would you like to discuss next? She would like to know more about mortality. So it's over 10 years, 1,000 patients like you, 6 fewer deaths. She could look at this visualized with heads like this. She was concerned about the practical consequences, basically having to take a tablet every day for 10 years. Finally, she could balance. This is actually what she gets. 1,000 patients like you with aspirin, 6 fewer deaths, 28 fewer heart attacks, 20 more bleeds. She decided not to take aspirin. And then we go on the whole circle. And this is fine. This is a weak recommendation. This is actually what we want to happen. And if you do this with statins, like Bruce Guthrie was talking about, I think quite many patients would want to make a well-informed choice and not to take this treatment. So that's the story. Trustworthy guidelines should answer questions by relating best current evidence to clinical decisions. They need to be easy to find, use, and understand at the point of care. They should facilitate shared decision-making. We will continue to improve our strategies and our formats. And we really hope you would like to test them, use them, and help us move this field forward. Thank you.
Thanks a lot, Per. So our next speaker is Melissa Brouwers. She is an associate professor and head of health service research in the Department of Oncology at McMaster University. She's the provincial director of the program in evidence-based care, Cancer Care Ontario. Amongst many other things, you will know her because she's an international leader in advancing the gold standard of guideline development as the PI of the AGREE 2 and AGREE 3 projects. And she's come all the way here to tell us about the new developments of the AGREE 3. Thanks, Melissa.
Thanks, Pablo. And I realize I am the gatekeeper to the wine, so I'll keep it brief. So the title I gave Pablo originally was this, but I've changed it to the AGREE Rex. I think it's a better representation of the project I'd like to talk about, which, and this is the first of many acronyms you're going to be bombarded with, the AGREE Recommendations Excellence Tool. Can I just ask if anybody has heard of the AGREE? Can you stick up your hand if you've... Well, that's reassuring. That's good, because the genesis of this project came from the original work that we did with the AGREE and the AGREE 2. Just in case you haven't heard of it, the AGREE 2 is a refinement of the original AGREE instrument, and it is geared towards critical appraisal of clinical practice guidelines, and it's also geared towards informing their development and reporting. Now, in the early days when we started to think about developing an appraisal tool, and it was really launched by Françoise Clouzot in the early days, we viewed the guideline process as both a social and scientific process. And therefore, the AGREE instruments cover all of that. And the things that I've listed underneath, scope and purpose, rigor, applicability, etc., are the domains of the AGREE. And you see elements of methodological issues as well as the social issues. Who's involved, managing editorial independence, and the like. So this focused on the entire process and the entire guideline enterprise. What we wanted to do next, though, before I go on, I just want to do a sidebar. I stuck this in this morning because people always ask, isn't the AGREE 2 and the Grade Decide project the exact same thing? And I'm sure Grade Decide people get that question. We get that question all the time. And the simple answer is no, they're not. What we have done is, with the Grade Decide tools and methodologies, they're embedded as exemplars of AGREE 2 items. So in other words, if you see a grade or decide method being used, that would increase the relevant AGREE 2 item quality score if used appropriately. Also, in the AGREE components that speak about reporting and development, the grade and decide tools and methodologies are used as exemplars around templates that could be followed. However, and I'm sure all of you have experienced this, sometimes people don't apply the grade and AGREE tools appropriately, and so therefore they may be evaluated less well on the AGREE 2 tool where the relevant item is, and that there are other exemplars that we've also included in the AGREE 2 instrument. So that's a little bit about the agree, the process and the interface between grade and decide. Now, what is Agree Rex? This is a new project that we're undertaking. And instead of looking at the entire guideline process, what we're interested in doing is focusing specifically on the recommendations. And our question is, how can we make the most implementable, high-quality recommendations? So the intent with the Agree Rex is to develop a complementary tool to the Agree to think about strategies to be able to differentiate between recommendations that are of good clinical quality and validity or trustworthiness and those that aren't, and to also guide the optimal development and reporting. And here I can already see the interface between the two projects, and I'll speak more about that. So we've done multiple steps towards getting towards the Agree Rex. We're not done, but what I want to do is focus on some of these steps. We began with a realist review, and the focus of a realist review, it's a knowledge synthesis method, is it's a great way to look at theories and mechanisms underlying processes. It's a great way of working with literatures that are diverse from different disciplines, and it helps develop a concept. And our concept in this case was guideline implementability. Systematic review methodologies don't do that sort of work, so that's why we chose the realist review process. The question we wanted to ask, and what we did ask, are what are the features of guideline recommendations that influence their actual uptake? By whom, and what circumstances, and what context, and why? And the focus that we wanted to do was to be one that was multidisciplinary in terms of looking at the literature. What we wanted to do is to begin the process of creating a common language and nomenclature around guideline implementability. One of the challenges in the scientific enterprise is we're saying different things that mean the same underlying concept. And that really leads to another key thing around improving the scientific enterprise, which I'll come to in a moment. I don't want to go through the whole process, but enough to say that there's multiple steps, and the literatures that we looked at are medicine, management, psychology, and human factors, and within that, subdisciplines that are incorporated into those core disciplines. But it is a rigorous methodology around looking at different literatures. The results of our realist review were 1,571 intrinsic guideline attributes that were found within 367 studies. Through a process of squishing and argument and consensus building and squishing some more, we got to 6 core attributes comprising 6 core domains, that should read, comprising 28 attributes. So the 1,571 made it into 28. We called this contraption, another lovely mechanism, guideline implementability for decision excellence. I think we're on a thing around excellence model, called the Guide M. Below is a picture of the Guide M. You don't have to know what it says in there because I'm going to take you through some of the layers. The second step with the Guide M, which I'll show you in a minute, was to do a content and construct validity process. We wanted to do a structured process where we got feedback from researchers, developers, and users in the guideline enterprise. And we wanted to ask questions around how the components were organized, the labels for the different components, the logic, relevance, appropriateness, and overall quality as it relates to guideline implementability. In this process, we had 248 participants representing 34 countries in this validity step. So I'll walk you through. The one core component was called content, the one core domain, and it was comprised of stakeholder involvement, evidence synthesis, considered judgment, and feasibility. As you can see here, 7 being the highest rating, the scores around the logic of the cluster, the appropriateness of domain levels were scored high. The second core concept was communication. That was looking at message and formatting. Again, very high scores. When we looked within each of the components and looked at the logic, the relevance, the appropriateness, and the overall ratings, again, in each case, here we have for stakeholder involvement, evidence synthesis, considered judgment and feasibility, high scores, and communication, again, high scores on each of this. That was very reassuring that people in general sort of liked the Guide M model. But then we asked for open feedback. Do you have any suggestions? When you ask for suggestions, you get suggestions. And we had many suggestions. So we went through a process again to create the final Guide M, squishing and thinking and consensus building and looking at the feedback. Does the language, this is an English language model, but does the English language representation we have, does it align with how people use English in other countries, et cetera, et cetera. Our final Guide M is comprised now of 3 tactics, 7 domains, 19 attributes, 44 sub-attributes, 43 elements, and sub-elements. And I know what you're saying. Why, as guideline users and developers, would we care? Don't forget, in an earlier slide, I talked about we're trying to advance the scientific enterprise. For people who do this sort of work, what we're hoping to do is have a common and public resource where this entire thing is represented with the reference, with the evidence, with the language, with all of those sort of things. So we have a mechanism to build from. It starts the dialogue. That's really what we're after. For most guideline developers and most guideline users, we think that the first 3 layers are probably most important. So this is a squished little version of the Guide M, the final Guide M. We now have 3 tactics. Who's developing, what they're developing, and how they're communicating what they've developed. Within the developers of content, we look at the makeup of the group, are they knowledgeable and credible, and how are competing interests addressed, and we look at various competing interests. With regards to creating content, there's the issue of evidence synthesis, the how, the what, the when. That's not rocket science. We have a lot of information about that. And what we call the contextualization and deliberation component, which is looking at the clinical credibility, the values and feasibility from multiple perspectives. If you go further deep into the elements, sub-elements, sub-elements, et cetera, the other 100 bits, that's where you can find the content of that. And then the communicating content, we have landed on the words language and formats that target that aspect. So this is the final Guide M. Our step 4 was to pause and then to prioritize. And in this, what we wanted to do is, the goal of the Guide M, because it was much bigger than our original piece of work, was to let's look at some selected tools, the tools that we all sort of know about more or less, and let's juxtapose them or place them on top of the Guide M to really see where are the gaps as it relates to guideline development, which is one tactic that we need to consider, guideline reporting, which is another tactic we have to consider, and guideline appraisal. So we did that. And what did we find? We did it at the attribute level. And what these different colors represent are the lighter colors are things that are pretty well taken care of, and people don't think we don't need too much more. The middle blue colors, sort of the medium blue, are things where there's some development, maybe not quite enough, or we're not quite convinced, or it's not very practical. And the very dark colors are ones where quite a bit of work. So as it relates to guideline development, how we develop our guidelines, you see that we have some light blue, some medium blue, and one dark blue element. When it comes to how we report the information that we need in a guideline, we see a few light blues, some medium blues, and a little bit more dark blue. And when we focus on appraisal, light blues and some dark blues. Overall, what we found, as it relates to developers of content, there's already been a lot of work around this. People know around the multidisciplinary aspect, et cetera, et cetera. The issue around competing interests or conflicts of interests, however the term that you most like to use, that was considered one of the least developed components as it relates to development reporting and appraisal. With respect to creating content, evidence synthesis is covered. A lot of people would suggest it's too much. There are too many things out there around the evidence synthesis. The development and reporting is underway for the contextualization and deliberations aspect. Issues around preferences, values, clinical significance, resource constraints, all of those sorts of things. And considerably more work is required for appraisal. And with respect to communicating content, quite frankly, that was seen as having the most opportunities for development, reporting, and evaluation. And so it's quite interesting to see the work of MAGIC and other work that the Grade and Decide group are doing around the layers, and how this work may be able to feed into some of the evidence that we understand about that communication aspect. All right. So I've talked about the GuideM. That's the big model with like a jillion different bits to it. How are we going to use the GuideM to get to where we really are trying to get to, which is the AGREE-REX, a tool targeted at recommendations? Well, what we're going to focus on in this next piece of work, which is really the core piece of work, this realist review and creating the GuideM took much longer than we ever anticipated, is that we are going to focus back on the contextualization and deliberation components, because that aspect of the recommendation component is one that needs the most work. For the AGREE team, the appraisal aspect will be our focus. Not only do we want to understand how these things are being done and reported, but do we have any evidence about how to do it the best? And a lot of the work in this area, more primary research needs to be done. What is the best way to gather values and preferences? Is it by bringing a team together of patients? Is it to bring a team together of clinicians to get their perspective and of funders, etc.? What are the best tactics? We honestly don't know for a lot of the components. The other key thing is that we're having formal collaborations around the development and reporting. We'll be meeting with the deciding grade group. So, for example, with the evidence to recommendations team, part of their work is to look at existing methods, maybe develop some new methods. How can we share that load? And how can that then influence the AGREE team as it relates to appraisal, for example? Now, in doing this with the AGREE-REX and how we're going to do it, one of the things for our team that has given us pause is that we're really trying to pause and think, do the new methods and strategies that we want to embrace or start to develop, do they reflect meaningful, important advancements? And who's going to benefit from these advancements? And are the partnerships and collaborations that we're seeking or need to seek optimized? There's always jurisdictional ownership, there's intellectual ownership, there's discipline ownership, and there's professional ownership around how we're moving things forward. But who's going to benefit, and are we making advances that are meaningful enough, big enough, and worth the effort? And why should we care? I think we need to care because every guideline advancement, everything that we suggest as researchers and people who are methodologists that we place on guideline developers and users, it requires change, it requires time, and it ultimately requires resource, whether that's more people or money. So we need to show people that our incremental advancements are worth it. And I'm not convinced that we're doing a great job on that yet. Is it worth it? So with the AGREE-REX team, what we're trying to do is not only try to do really good work, but also consider when is good enough. We can keep striving for perfection, but there's a cascade effect for everyone involved in the guideline enterprise. And we have to really think, is that one extra step important enough? So we can do anything. That I don't think is a problem. But if everything that we could do in the guideline enterprise, when we think about the time, how much money, the limited resources, there's only so many people, what should we do? So part of thinking through that is really wearing a hat of the ivory tower versus real life perspectives. We can't just do academic exercises. We need to do exercises and advances that can really work in real life. And many of you totally understand that because you're guideline developers and interested in advancing quality. We have to be careful around dogma versus evidence. Just because we repeat things over and over does not necessarily make it true. Where is the evidence supporting what we're doing? And again, of all of the things that we could do based on evidence, are there any super compelling areas that we should really spend our time and energies on? What's the issue around statistical significance versus methodological significance? And here what I'm trying to articulate is this idea that even if we do randomized controlled trials, and we've done lots in developing the AGREE-2, and we get statistically significant stuff, is it methodologically compelling? If we're going to ask people to up the ante in quality, is it worth the effort? Is it a big enough leap? Is it a big enough next step forward? And balancing the idea of rigor versus feasibility, which links up to this concept of things have to work in real life. So those are the principles that the AGREE team is trying to embrace as we're going forward in this enterprise. So I invite you to stay tuned. The AGREE Rex is coming. Our goal is to make it rigorous but useful and pragmatic. We want to be able to optimize collaborations with our colleagues. And what we're hoping to do is to create a set of tools and resources and strategies that can help the guideline developers who are creating the guidelines and the recommendations, clinicians, policy folks, system leaders who are using guideline recommendations in their decision making, and most importantly, the recipients of the guideline action, which is our patients and our populations. And that's where we have to keep the lens on. I'd like to acknowledge our research team. As you can see, the AGREE-REX research team is huge. And I also highlighted Pablo and Holger's name because they invited me to come. So thank you, gentlemen. That was very nice. And we also have Jaco and Francoise, who are also in the audience, who are part of our team. So this is very nice. And thank you very much.
Thank you for those great two talks. I cannot believe that you don't have questions for Melissa and Per, so please go ahead.
One question for Per and one for Melissa. For Per, what about the decision analysis in the format which you described? Is already out of the picture, no more utility, disutility, probability, and all these things? And the question for Melissa, having the name AGREE-REX, this is another ownership, and the collaboration might get problematic with that. Why not a new product which collect the IOM, the McMaster Grade and Pro, and the AGREE? But pulling the other two big organizations or big bodies for guideline development into AGREE might be difficult, isn't it?
Okay, yeah, so for our work on shared decision-making and decision aids, we've followed the model developed by Victor Montori, the Mayo Clinic, and also similar to what Glenn Elvin and others have done in terms of their option grids, moving away actually from the decision analysis and evaluation exercises and letting patients make decisions based on best current evidence. Their decisions will reflect their values and preferences to some extent. It's another way it's a different way of doing shared decision making than the traditional decision aids. It's an alternative, additional model that we believe is good for creating conversation in consultations. So it's based on a different model. Thomas Aguritsas, where are you? So he can talk to you more about this, and the workshop on Wednesday will be good for discussing these issues. Okay?
Thanks for the question. Is there an IOM author here? Okay. I know you, so this is okay. I appreciate the work that went into the IOM standards. The evidence supporting the IOM standards is modest at best. It is a complex set of standards that are very difficult to implement. And one of the challenges, I think, with the IOM standards is it sets the bar, without any evidence, exceptionally high. So, and we have talked to the IOM folks a lot around collaboration and those sorts of things. So to squish with the IOM, because don't forget, the IOM standards emerge as an act of Congress. It was driven by an act of Congress in the U.S. And to merge with them, I think there's a lot of complexities. Now, merging, or I'm not sure if it was a merge or however you suggest, with decide and grade, well, there was even, we're having, I don't want to presuppose anything. So we have had chats around, there is some overlap. The reason it was Agree-Rex is this, the Agree-Rex and this started so many years ago to get to this, that it even came before Decide started, the Agree-Rex project. And the Agree came before Grade, so that's why that is. It's a great brand. And so we're using it to our advantage around brand. It gets people interested, it gets people listening, and it gets people participating in the studies that we're doing. Would the same be true around Grade and Decide? Yes, absolutely. So how to manage that landscape? I think that requires a big discussion because you can't force groups together. But I think it's a point well taken. So with the IOM, I think the challenge with the IOM standards is I'm not sure there's an appetite to integrate. And in contrast, I don't love it. I don't love the IOM standards. I think there's a lot of people who don't love the IOM standards, but they have a lot of traction and maybe not for the best reasons. Do I think it's an awful tool? Absolutely not. Absolutely not. But I don't think it's the be-all and end-all. I think lots of work had been happening in Europe and Canada before the IOM standards came to be.
So I have a question for Per-Olof. If you say that we should not write grade 2B, what should we write instead? What's the current recommendation?
Yeah, well, thanks for that question. Maybe it wasn't clear enough on that. So we haven't got the final answer on that. From our user testing in the SciWork Package 1 and also in our survey trial, it seems like stating whether it's a strong or weak recommendation or whether you call it conditional or weak, that's a choice. Stating whether it's a strong or weak recommendation and color coding seems to be a promising approach. We're going to have a workshop on Wednesday with Nancy Santesso. You're here, Nancy. And we're going to talk about the best way of communicating the concepts of strength recommendations and confidence in the effect estimates. And, you know, icons didn't work that well, or symbols didn't work that well in our user testing, but then Sarah Rosenbaum and other people have done work on that. So now we have to get together and look at what we have in terms of the evidence and best ways of communicating this. Letters and numbers does not seem to work. It's been repeated, pretty consistent feedback that people are confused. They might get the gist of a 1A being better than a 2C, but that's about where it stops, I think.
Thank you.
Yeah.
Yes, please say your name and institution, please.
I'm Robert Fauji. I'm a GP. Oh, right. Seriously, kind of got here. I haven't got one of my kids to show me how to do it. Right. Normally I have to do that with technology. Yeah, I'm a GP and just a few miles down the road from here. And I like the question about what we should use instead of things like 2B and 1C. And what I think we should do is to use the same language to each other as we would use with patients, because that's what's really understandable. And we don't want to have two separate different sets of language with which we're going to communicate whether or not someone should take a particular drug or not, or what the benefits are. And I think if we use the same language together and got a common language between patients and doctors, that we would all understand that much better.
Yeah, I agree. And
Me too.
And it's actually now interesting to see when you have these different tools showing the same information, basically. You have the key information section, you have the evidence profiles or the summary finding tables, and you have the decision aids. I wouldn't be surprised if also clinicians would like to look at the information we have in decision aids as the best way of communicating risk and certainty. So I think we'll learn from what we're doing and ideally end up with the same language. That's a good idea.
Hi, Joshua Vogel, WHO. Thank you both for very interesting presentations. I was wondering if you could expand a little bit on this issue about shared decision making and the need to simplify information for patients and individuals to try to understand it. And I feel like on the one hand, you're working to address a big limitation in making the evidence more accessible, better laid out, and more quickly accessible at the point of care. But what about this issue about the variation in what patients understand? And could you expand a little more on just decision aids? Are there other initiatives or other attempts to sort of simplify evidence base and guidelines so patients can make better informed decisions?
Yeah, right. And others, and Thomas might expand on this, but I think one advantage of having tools that are used in consultations, in a discussion between a healthcare provider and a patient, that you're actually able to clarify to a larger extent what the patient understands or to what extent they want to engage in shared decision-making, as opposed to standalone tools. So when we do our user testing and I look at clinicians using this tool, sometimes they put it away or stop, and they quickly realize patients are not ready, might be cognitively impaired or acutely ill or something, that this doesn't work. And then we have to look at, again, through our research, how well patients understand this information. I think the work done by Victor with the same model, with the decision aid card, shows that people basically do get this information, at least as well as we do as clinicians. But again, some patients would not want to engage in shared decision making. They would still like us to make some decisions for them or want our advice. Others would really like to do this. And then I think we'll see, people might stop taking drugs like statins or other drugs because they were surprised over the limited benefits and the potential harm, for instance. I'm not sure if that fully answered your question.
Well, also, if we struggle with concepts of quality and certainty, then it seems fair to expect that patients and individuals would struggle with it too. Have you looked at that specifically? Or?
Yeah, so that's one of our research questions. We actually do provide information about the certainty in the effect estimates or the results in the decision aids. I think we're the first to do it. I think Victor, for instance, is a little bit opposed to us doing it. We want to explore why not patients would also want to know about uncertainty. And so far, Thomas, could you help us a little bit about some initial insights from the user testing?
Hi, I'm Thomas Agovitsas from McMaster, and I'm working on this Decision Aids project. It's very early to draw any conclusions, but when we were working on a framework on how to do it, we were surprised by the very contrasted opinions. Some people saying, never show anything about certainty or uncertainty to patients. Don't try. It's already confusing. It will be more confusing if you do. And some other people who say, absolutely, it's necessary. Think of the hormone replacement therapy, for example, recent history. Well, there was quite a strong recommendation. Well, back then it was maybe not labeled as strong, but clearly it was disseminated as we should prescribe hormonal replacement therapy based on observational studies that we will now label as, with low confidence or even very low confidence sometimes. So would women have chosen differently if they had known that there was uncertainty about the evidence we were showing them? Well, maybe. And I think what attracts me in that research particularly, and within Grade and Decide, and others people interested in that, is that it's a new paradigm that you can actually have a strong recommendation and do it, and if you don't, you're a bad doctor, you're unreasonable, or you don't understand, you've not been informed. And a weak recommendation where actually, if you want a recommendation, you have one. The guideline panel has thought about it, and you get a weak recommendation for aspirin. But if you don't want a recommendation, you actually want to engage into shared decision making, then you can. All that effort into building databases to assess the evidence, to be able to present it in different ways, may allow that. But if patients don't want to, well, you have the weak recommendation that you can share, and you can have as much confidence as we do by saying, it's a close call, but I would recommend that you take it in your case. So I think it offers that choice, and in our early user testing, that's maybe that's too early to tell, but that's what we see.
And are you doing just physician-patient, or with families and partners present as well? Or?
So you cannot say to partners and family to leave the room, so it has happened that they stay. And it's very interesting because there are different ways of doing that. And maybe a short anecdote, the doctor wanted a teenager to engage into decision, and she kept the decision aid, which was an iPad, between her and the patient, the teenager. But the family followed, and they wanted to look at. So yes, we do engage into some user testing with family. We have not done in pediatrics yet, but why would it be different? I don't think it's. What we know from shared decision making is that it can happen with one person or with several persons in the room, and maybe it would highlight that the decision is about the patient.
Any more questions? Well, thank you very much, Melissa and Per, for a fantastic and stimulating discussion, and everybody else. And just before you leave, there are a couple of messages, housekeeping issues from Sean. Thank you.
Thank you, Pablo. Nothing much. So Melissa said that she was the gatekeeper to your wine. That's not correct. I am the gatekeeper to your wine. But one of the items on here is merely to say there is wine, and it's out there somewhere close. So that was one thing. The other issue is two issues. One is there is a comments board, and somebody was asking me to encourage you to write comments, and I was thinking perhaps after a couple of glasses of wine would be an ideal time to approach the comments board and think about writing something. And the last thing is, just before we came in here, I was handed a ring that was found in the ladies' toilets, not by me, but if somebody, probably a woman, has lost this ring, it's square with some little round designs on it, I have it, and I'd be happy to give it you back. And that's it for today. Many, many thanks for your contributions. All been very welcome. And hopefully all of you, or most of you at least, will be here tomorrow bright and early at 8:30. But right now, wine. Thank you very much.